Day and welcome. My name is Catherine Castro, and on behalf of the Guam Chamber of Commerce, the Guam Women's Chamber, and the Guam Hotel and Restaurant Association, I am pleased to welcome you to our virtual town hall regarding the COVID-19 vaccine. You are in the right place if you are interested in learning more about the vaccine and the rollout plan for Guam. I'd like to thank our guest speakers for taking their time to be here this evening. I'd also like to recognize our leadership present from each of the sponsoring organizations. And additionally, I'd like to recognize the Speaker of the 36th Guam Legislature, Therese Terlahi, for being with us here tonight. We do have a few housekeeping notes before we get started. All participants are on mute during today's presentation. If you have questions for our guest speakers, please feel free to send them via the question feature located on the right corner of your screen. And our moderator will be sure to pass your questions along to our panelists during the Q&A portion of the program. So let's get started, shall we? I'd like to introduce Crystal Paco San Agustin, who will be the moderator for today's session. Welcome, Crystal.
Day, thank you so much for having us. My name is Crystal Paco San Agustin. I'm the Director of Communications at the Office of the Governor of Guam, and we're so happy to be able to do this vaccine virtual town hall for all of you. This would be our fourth virtual town hall. We started with the general public, then we proceeded to the FAS community, then to the public school community, and now we're honored to be here with our business community. So we did find that majority of the questions fell under five main subjects. Those subjects are, is the vaccine safe? I'm concerned about side effects. What are they and should I worry? Can I still get COVID-19 after I get the vaccine? Does it protect against new strains? What if I had COVID-19? Do I need to get the vaccine? And last but not least, how are vaccines being disseminated? So I'll introduce first our panel. Our panel here with us tonight, we have Dr. Felix Cabrera, the Department of Public Health and Social Services Chief Medical Officer. He is an internal medicine doctor. He is the son of the Marianas, having been born and raised on Saipan, and now a practicing internal medicine hospitalist on Guam. He graduated from the University of Washington with a Bachelor of Science degree in medical technology. He went on to earn his medical degree from the University of Washington School of Medicine in Seattle and completed his residency in internal medicine at the Yale New Haven Hospital, Yale School of Medicine in Connecticut. He is board certified by the American Board of Internal Medicine. He is also a member of the American College of Physicians and the Society of Hospital Medicine. He has practiced in the Marianas since 2011. In addition to a primary care practice, he previously served as a hospitalist at the Guam Memorial Hospital, eventually as the Associate Medical Director until 2014. He currently holds privileges at both GMH and GRMC. On occasion, he returns to Saipan to provide coverage as a locums. Some of Dr. Cabrera's professional interests include teaching and mentoring clinicians, medical informatics, implementation of evidence-based best practice models, physician well-being, geriatric care, and community outreach and palliative care. We also have Dr. Thane Hancock. Dr. Thane Hancock was born and raised in Hawaii with an older adopted brother from Yap. Dr. Hancock received his bachelor's degree in anthropology from Amherst College in Massachusetts, and then returned to the University of Hawaii for his master's in public health, MD, and residency training. Upon completing his family medicine residency, Dr. Hancock accepted a job with the Wa'op Community Health Center in Yap, Micronesia, where he fulfilled his National Health Service Corps commitment, working as a family physician. While there, he reported the world's first identified outbreak of Zika in 2007. In 2011, he joined the US CDC's Epidemic Intelligence Service, where he worked in the Outbreak Response and Prevention branch of the Division of Foodborne, Waterborne, and Environmental Diseases. In 2013, Dr. Hancock returned to Yap State to serve as a physician with a focus on non-communicable diseases and to assist the Yap EpiNet team with outbreak surveillance and response. In 2015, he moved to Guam and joined CDC as the agency's senior medical epidemiologist for public health emergency preparedness and response in the U.S. affiliated Pacific Islands. We also have on our panel tonight Dr. Dolores Lee. Dr. Lee is a family medicine physician at Evergreen Health Center in Maite. She was born and raised on Guam, and she is a graduate of Notre Dame High School. She received her Doctor of Medicine from and completed residency at the University of Hawaii at Manoa, John A. Burns School of Medicine. She is board certified in family medicine and is a delegate to the Congress of Delegates of the American Academy of Family Physicians. In addition to providing care to children, adults, and our manamku, she teaches students as clinical faculty for the University of Hawaii and community faculty for Maryville University. She's also helping with the University of Guam's Micronesia Geriatrics Workforce Enforcement Program, and she is a board member for the American Cancer Society Guam office. Rounding out our panelists for tonight, we have Dr. Louis Cruz. He's a member of the State Surgeon Cell as the COVID-19 medical planner and battalion surgeon. Dr. Cruz was born and raised in the village of Jotnya, and he's dedicated to improving the health and wellness of the people of Guam. He currently provides primary care and sport medicine services at American Medical Center. He received his BS Civil Engineering at UNH Manoa, but quickly changed his career course to medicine, obtaining his BA in chemistry at the University of Guam. He's a proud graduate of the University of Hawaii Imaho'oloa program and the John A. Burns School of Medicine. Dr. Cruz is an assistant clinic faculty at in the UH Department of Family Medicine and Community Health. He completed his family medicine residency and sports medicine fellowship at the University of Arizona, Tucson. He is a team physician for several sport federations and Guam's Olympic team. He attended the 2016 Rio Olympics and hopes to attend the 2021 Tokyo Olympics. He serves on the Oceania National Olympic Committee's Medical Commission and the GNOC Medical and Anti-Doping Commission. He is also a major in the Guam Army National Guard, where his current role is battalion surgeon. He has been activated throughout the COVID-19 pandemic as part of the State Surgeon Cell, assisting in the pandemic response. He's very passionate about changing our island's health, working hard to break the cycle of generational disease at a government and community level, one patient, one family at a time. Again, that is your panel for this evening. And without further ado, I'm going to go ahead and give the floor to Dr. Cabrera to start off his presentation.
There we go. I'm unmuted now, so I will go ahead and share my screen. There we go. Can everybody hear me?
Yes.
Okay, great. Thank you. And you can see my screen, right? It says Town Hall.
Yes.
You're all good.
Coming.
Okay, great. Thank you. All right. So thank you, everyone, for joining us this evening. What we hope to do today is just to go through just a few slides just to kind of get the momentum rolling here. Won't bore you with too many things, but we sometimes it's good to have a visual guide to guide our discussions overall. So let's just jump right into it. So just a very quick overview of where we are right now. So on Guam, there's been 7,568 infections with COVID-19 with 129 COVID-related deaths. Obviously, this created unique challenges for us, but also at the same time, Guam has some unique advantages, which we can discuss further at some point. But right now in the United States, there's been over 25 million infected and almost 430,000 COVID-related deaths. Unfortunately, the deaths are projected to be about 550,000 by April 1st, and that's with rapid vaccine rollout. And then for the rest of the world, there's been over 100 million infected now, 2.1 million COVID-related deaths. And by April 1st, it'll be 3.22 million COVID-related deaths, and that's again also with rapid vaccine rollout. So today we have Operation Warp Speed, which is getting a name change, as I understand it. But right now in the US, they're vaccinating about 1.21 million doses per day, and there's been already 25 million people vaccinated throughout the country. You all may be familiar with the COVID area risk score. We're at 0.4 right now. And our active isolation cases were finally below 100, and we haven't been below 100 since early August. There's 8 persons in the hospital right now. We're doing about 460 tests per day as we go through. But then I'll just jump down here to the total vaccines given. We've given almost 24,000 vaccines already here on Guam. And by the end of today, we can probably add on close to anywhere from 500 to 1,000 more. We've used up about 70% of our stock. 11.2% of our population has already gotten at least the first dose. And over 5,000 are already fully vaccinated, and that's about 3.1% of our population. So right now we're vaccinating at a rate of just over 1,000 shots per day throughout the island. And just to go over the rest of where we are with the rest of some of the data that goes into the CAR score, our test positivity rates at 1.5%, our retransmission values at 0.8, and that's below 1 when that's what we want it to be. And then our daily new cases per day at 6.7, and these are on 7-day rolling averages. Okay, so jump into the questions. Is the vaccine safe and effective? Well, let's start by first understanding a little bit about how vaccines work very briefly and the history about that. So this is Edward Jenner, and so this is around 1770 or so, where he inoculated, it's obviously a painting of him inoculating a boy, an 8-year-old boy by the name of James Phipps. And this actually happened in 1796. And so this lucky but poor boy basically was the very first person given a vaccine, and he was the guinea pig, so to speak. So the reason how this happened, why this happened, is that both cowpox and smallpox are somewhat similar. And what they noticed is that cows that made people who work with cows also catch cowpox, in particular milkmaids, that they will recover. This will usually be a mild version of the pox, and they will recover. Well, what they noticed was that they were not susceptible to getting smallpox. So then Edward Jenner theorized that, well, let's take a sample of what's going on here. Let's inoculate James and give him cowpox. He came ill with a mild case of cowpox. Then they literally took scabs and collected from some other person that did have smallpox, and then poor James, James Phipps, yeah, they inoculated him with smallpox, but successfully he was vaccinated and did not develop any disease and was unaffected. And so that was the first successful vaccination that ever occurred. So that was pretty neat. But he was the Edward Jenner's, I think, his gardener's son. I think that's what it was. So anti-vaxxers, it goes back all the way to when vaccine started. This is back in 1802, where people were concerned about this whole process, saying, "Oh my gosh, you're gonna give us pox that look like cows, and it's gonna grow out of our noses and our mouths and our butts." And so you see a depiction of that here from back then. Okay, jumping a little bit more current, the coronavirus. And so this is an electron microscopic image of coronavirus. And the reason why it's called corona is because it looks like a crown. And so that's where it gets its name, where it have these unique spike proteins that go around it. So if you didn't know that, now you know. But you might be more familiar with this picture of COVID, or SARS-CoV-2, as it's otherwise called. And so then here you see the spike proteins in a more of a 3D image. So basically the vaccines against COVID are targeted against these red areas. Again, the spike proteins that are on the edge of the virus here. And so what the two vaccines that are currently being used, both the Pfizer and the Moderna, it's basically an mRNA mRNA that is basically only for the spike protein, not the entire virus. So it's only the mRNA. So basically it's like the source code for just that part of the virus. It comes into our body, we get the shot, it comes into our body, and then our own body actually takes the mRNA and actually synthesizes the spike protein ourselves, and then it spits it out for our immune system to recognize this as foreign and say, hey, I don't know you, you are foreign, and then it starts training and learning, and then when it does see an actual coronavirus, then it can actually attack them very easily because it now recognizes that. And so this is how it works. And going back to here, your DNA lives in your nucleus. The mRNA never goes into the nucleus. It stays outside. And so it can affect your DNA. That doesn't happen. But this is also quite unstable, and it eventually will just disappear from your body, and kind of like a Facebook or Instagram story. It will disappear after a few days and will only make enough for you to develop your immune system. So moving along real quick here, this is slides that we're taking from Dr. Annette David, who typically joins us on these town halls, but I was just going to use a few of her slides here, and just to help us understand basically when we're talking about safety, I'm mainly going through what people were concerned, like this vaccine was developed so quickly, and is it safe? Was it rushed through? Well, it was not rushed through. There were a lot of resources that were put into doing it well and in a timely manner. But basically, this is how vaccines are studied, where they go into three main phases. The first phase is mainly taking a small amount of healthy volunteers and asking, is this vaccine safe? They give it to them and they watch them, and if it looks okay, then they move on to several hundred volunteers, and then they look at what might be the safety in this aspect here, and how are they responding overall from the immune system. And then if they feel like it's safe enough, and there's an independent panel that monitors the safety in this process, then they jump to phase 3, where hundreds of thousands of volunteers are involved. For example, the Pfizer vaccine, there's about over 43,000 people that are involved in the phase 3 trial. And then they compare the efficacy of the trial. So you have one group that is a placebo group that actually doesn't get the vaccine, and then you have another group that is vaccinated, and then they compare in the real world, do they get COVID or not? And so basically the ones that were in the placebo group, they were more prone to getting COVID, and then the ones that were vaccinated were not. And the reason why this occurred very quickly also is because you have to do this in the real world, and COVID is so infectious. So we actually got that answer fairly quickly. Now, example for HPV, which is the virus that can cause cervical cancer, that takes many years to even decades to find out if that vaccine is even effective. And so that's why some vaccines take many, many years. But in the case of COVID, just by nature, we got our answer quick, even more quick. So the two that are right now given a FDA emergency use authorization is both the Pfizer and the Moderna, and they're both around 95% effective. That means that basically out of 100 people who get the vaccine, 95 of them will actually be fully protected from getting COVID, and there will be an unlucky 5 that will still get COVID, and is what the data has been telling us here. And then AstraZeneca, the one that's in partnership with Oxford University, is about 90%, and Johnson & Johnson, and these and they're still being evaluated by US FDA. Johnson & Johnson is 97%, and this has the advantage of only being a single dose vaccine. And then you have the Novavax, who it's still also being studied right now. So these are the top 5 as we have it. And so the key thing to understand is the efficacy overall, and how important that and how impressive this 95% is. That the WHO just said that for this pandemic to be under control, we just needed a vaccine that was at least 50% effective. Well, we got 95%. And so I think we can be very happy with that. The flu vaccine itself can be around, it averages actually only around 40% effectiveness. Sometimes it's 60 or above, but that's how effective the flu vaccine is. But the key thing is that what we do want the vaccine to do at minimum is reduce not just if you can get the virus, but if you were to fall very ill, will getting the vaccine prevent you from falling so ill that you may end up in the hospital, or God forbid, die from COVID. Okay, so that's a mouthful. I'll jump to the next question here. And this question will go to Dr. Hancock. I am concerned about what side effects, what are they, and should I worry? And I'll toss it over to Dr. Hancock.
Thanks, Dr. Cabrera. I really appreciate your review there. And, you know, before I really jump into this question, I just want to say, you know, just reiterate what you had brought up, you know, are these vaccines safe and effective? And, you know, when you compare these first two vaccines that have been approved in the US, their efficacy rates of 95% are just outstanding. And so I think we're really lucky. You know, it looks like, and you know, we'll see as these numbers play out, but you know, right now at the beginning of rolling out these vaccines, it looks like they are super effective. Dr. Cabrera, I'm getting a notification that my network connection is slow and I'm lagging. Am I coming through clear, or should I turn off my webcam?
I hear you loud and clear. Let me turn off my webcam.
Okay.
There you go.
So again, you know, these first vaccines that come out are super effective, and it really looks like you know, our scientists may have hit a home run with the first pitch as far as the vaccines are concerned. So that's fantastic. And you know, I think as we move through this really historic time, Dr. Cabrera brought up, you know, Dr. Jenner and his first use of a vaccine. This time is a historic one as well. That's going to go down in history. You know, the 2020 pandemic, and you know, the use of these vaccines to help slow the pandemic. Now, hopefully, it'll play out like we all want, where we've got a lot of vaccine, people get the vaccines, and we reach that immunity and be able to really slow this pandemic. I really appreciate the opportunity to chat with folks and help sort of share the good news that really is these vaccines. The second part of that efficacy is, you know, is it safe? Like, do I need to worry? And, you know, we know that vaccines, people tend to have to be a bit touchy about vaccines and worry a bit more about their safety. And so that's why those large phase 3 studies are done. And that's why, as Dr. Cabrera brought up, they use a placebo, which is, you know, just sort of a saline injection. There's no vaccine in it, and people don't know if they're getting the real vaccine or the water shot, and they get monitored. And the reason why they need to do that is, as you can imagine, and especially right now, as we're rolling out the vaccine in some of our most vulnerable parts of our community, individuals who are elderly, individuals that may have heart disease, that some of these people are probably, you know, they may have a bad outcome whether or not they got the vaccine, but because they got the vaccine, you know, a week before they got the heart attack that was set up to happen already, people might blame the vaccine. And so by being able to use those two groups in those studies, they look at the rates of adverse reactions between them and evaluate, you know, whether or not the people who are getting the vaccine have any more or have adverse reactions compared to the placebo group. And what they found in those studies is that actually you know, when you look at adverse reactions, the only thing in the studies, they didn't see anything actually that popped out in the studies. Now, the other thing that's going on is these vaccines are being really monitored as we roll them out globally, and especially in the US, and any adverse reaction is reported. And you may recall early on, there were some reports of people having allergic reactions to some of these vaccines. And you know, there are a handful here or a handful there. And they actually have looked at it now, and it looks like some people may have a severe adverse reaction to the Pfizer or the Moderna vaccine. This, fortunately, is extremely rare. So out of 4 million, there's a new publication out identifying these from Moderna. Out of 4 million individuals that received the Moderna vaccine, there were 10 people in the US that had anaphylaxis. And the thing with anaphylaxis is, if it's managed quickly and appropriately, it's reversible. So the individuals, there were no deaths associated with these. All these individuals did fine. But you know, there was that chance. And it's, you know, it's 2.5 in a million of having an adverse anaphylaxis with Moderna. And then with Pfizer, the rate's a little bit higher. It's 11.1 individuals per million that have had anaphylaxis with Pfizer. And again, that is why at all the immunization sites, that's why Dr. Cruz is at UOG, is just standing by in case there are individuals that develop anaphylaxis. Now, again, it's extremely rare, but really that's the one adverse reaction that we have found with these vaccines. Now, another reaction that people get, and that, you know, I see here in the question, is side effects. Side effects are different from adverse reactions, and these are sort of the normal symptoms that you would have as your body builds its immune system in response to the vaccine. Next slide. So as I mentioned, so we'll talk a bit about these a bit more, because these are way more common, and they find that maybe up to a third of individuals that get immunized with these vaccines do experience some moderate side effects. Next slide. The important thing to remember is that these side effects are expected, and they don't last long, usually about a day or two, and they don't, you know, they don't make you infectious and cause you to spread any kind of illness. It's just, again, your immune system ramping up, being ready to fight that spike protein. When that happens, you can get some pain around the injection area where you got the shot, maybe some swelling. And then throughout the rest of your body, you can have symptoms like fever, chills, tiredness, headache, fatigue. And those, again, are the products of the symptoms of your immune system really ramping up. And just to let you guys know, when I was vaccinated, I definitely got these. So it does happen. Next slide. The good news is there are things that you can do. So after you get the vaccine, if you do start to notice, hey, I'm feeling kind of like a fever's coming on, or my arm's especially sore, there's things you can do. So for the sore arm, you can apply a cool wet washcloth to your arm, and you can kind of exercise it, move it around. That can help. Next slide. Oh, and I'm sorry, I left out the part for the fevers and you know, headaches. You can go ahead and take ibuprofen or Tylenol, as long as you don't have any, you know, existing contraindications if your doctor says you shouldn't take it. But you can take some of those just over-the-counter analgesics, and that will help cover those symptoms of fever, headache, and that sort of thing. Of course, there may be things that we want you to watch out for. So when to call the doctor. If you have these symptoms if it tends to increase after 24 hours of getting a shot, like it's getting worse rather than getting better, that's a reason to go to the provider. And if they don't seem to be going away after a few days, another reason to perhaps go to your doctor. The last thing I want to talk about is, you know, again, there's a lot of scrutiny on these vaccines as we roll them out, and there's an opportunity for every individual who's been vaccinated to help provide additional information on these vaccines, on the side effects, how you're feeling after you're immunized. And CDC has rolled out a program called VSafe. And so when you get your vaccine here in Guam, when you're in the rest area, you'll be able to pick a little flyer or a little card that will guide you on how to enroll in VSafe. It's a CDC program. You need a smartphone to do it, but it basically is a way for you to check in with CDC and say, hey, this is when I got my vaccine. They'll follow up with you. You'll see the little picture there where they say, how are you feeling today? What kind of symptoms are you having? And you can report your symptoms that way. And it helps CDC better understand the safety of these vaccines as we roll them out. And also, if you do report severe illness or a lot of, well, if you have severe illness, of course, you want to report it to your physician. But if there are symptoms that CDC is worried about, you might actually even get a call from one of the physicians there that tries to help. They have physicians that try to help monitor some of the reports. But please do contact your local provider if you do feel that you're having symptoms that you're worried about. So that ends my session. Thanks, Dr. Cabrera, for driving the slides. I appreciate it.
No problem. Thank you, Dr. Hancock. So we're going to question number 3. Can I still get COVID-19 after I get the vaccine? Am I able to give COVID-19 to my family after receiving the vaccine? And who will be answering this for us is Dr. Dolores Lee. Dr.
Hi,
Lee?
good evening. Thank you, Dr. Cabrera. Good evening, everyone. Thank you for joining us and thank you for having us as we all together try to better understand the vaccine and try to address some of your questions and concerns. So, very simply and very straightforward and very honestly, can you still get COVID-19 infection after you get the vaccine? The answer is yes. And that answer would be yes for any vaccine. Vaccines don't, just because you're vaccinated with something doesn't necessarily mean that you're not going to be infected or get illness. But what the vaccines do is that they're designed to decrease the severity of illness and any, risk of developing severe complications from the illness itself. When we look at the 2 vaccines that are currently authorized for use in the United States, both Pfizer and Moderna, as both Dr. Hancock and Dr. Cabrera has stated before, they are 95% effective. And what we mean by the 95% effective is that, the endpoint for the studies that were showing us the efficacy of these vaccines is basically, are these vaccines able to protect us from having a COVID infection with symptoms? And so, it's 95% effective at preventing, that if you do get infected and you are positive for COVID, it's very 95 out of 100 people are not going to have symptoms. So you're going to have a very mild infection. And so this is very, very important, and it's why we're really focusing on vaccinating as much of the community as we can, right? Because as Dr. Cabrera stated earlier, we're really worried about this infection, especially when, people become so severely ill that it could, result in hospitalization and even death. And so, we really want to be able to take care of our vulnerable population, our elderly, our manamko, our friends and family with medical conditions who, if they were to get infected, that this would be very devastating in the sense that they would end up with very serious hospitalization. They may end up, they may survive the infection, but they also may end up with long-term complications. And so, to know that the Moderna and Pfizer vaccines are 94 to 95% effective at, preventing that, definitely it's reason to get the vaccine, so although the answer is yes, it's still very important that we get the vaccine. And then to answer the next question, are you able to give COVID-19 to your family after receiving the vaccine? So this is a little bit of a tricky question in the sense that, like I said, the studies that we've seen for efficacy are basically designed to look at a specific endpoint. And the specific endpoint, as I stated earlier, was, do you get COVID-19 and are you symptomatic? Not do I transmit it or do I spread the disease? Okay, so I'm going to say this very cautiously because, in terms of the studies, we're not designed to answer this question. But observationally, what we are seeing is that the vaccines are effective against preventing transmission from individuals who are infected and who do not have symptoms. And that makes sense, right? If we're saying that the majority of the individuals who are vaccinated, any of them who were positive, most of them didn't have symptoms, it makes sense that we're saying that observationally from the data that we do have in front of us, we're going to see that there is some protection against transmission. The other way that this makes sense is if we understand the disease process itself. Right, I've been taking, just like my colleagues here on the panel with me, we've all been taking care of COVID patients. We do it every day or most days of the week. Yes, we are wearing our personal protective equipment while we do it, but still, our risk of infection is very high. And so it doesn't mean, just because I haven't gotten sick or my colleagues haven't gotten sick, it doesn't mean that we haven't been exposed to the virus. It's about how much viral load we've been exposed to. And if we think about the way these vaccines work in terms of neutralizing the virus, should it come into your body, and neutralizing it, preventing it from entering your cells and replicating so that the viral load increases to a point that it makes you severely ill, then we can also say that, from this biological standpoint, if we understand how these vaccines work, that likely that they are going to prevent transmission, because if it results in an infection where the viral load is not high enough to make you severely ill, it's very likely you're not going to be shedding as many viral particles and you're not going to be as infectious. So even though we don't have the data, we do have the understanding that it's very likely that it's not going to result in transmission. But again, we're going to say that very cautiously because the studies were not designed for this. Additionally, because, as Dr. Cabrera shared, in terms of our percentages for vaccinating the population in terms of where we're at, and I'm sure everyone has seen Dr. Fauci on the news, we understand that in order for the vaccine to really help us to get back to a place where we're going to feel comfortable about reduced risk of transmission in the community, we have to vaccinate 80% to 90% of our population, and it has to be effective vaccination. So that being said, we're still going to ask that everyone, takes all the steps that we need to in order to reduce the risk of spreading COVID-19. And so you've heard it time and again. I'm going to say it again. We need to wear our masks. We need to wash our hands. We need to wipe our surfaces. We need to watch our distance from one another. And we have to have the willpower to do that 100% of the time. So again, like I said, I'm going to say very cautiously that there may be some protection against transmission, but until we know further and we have, data to really support that, we're going to ask you to continue to do all of the things that I just mentioned. So thank you. I hope that answers the question, and we can discuss it more in the question and answer session.
Great, thank you so much, Dr. Lee. We'll move on to the next question. Number 4, what if I had COVID-19? Do I need to get the vaccine? Does it protect against new strains? And to answer this is Dr. Luis Cruz.
Hi, thank you for inviting me to speak. I am here at the UOG vaccination site. It's we're getting a lot of people vaccinated. I am the incident commander here, so if you hear a lot of noise in the background, it's because we're trying to make this more of a joyous, lively occasion, and that, it is important that you get vaccinated. And so that being said, go ahead and answer the question of what if I had COVID-19? Do I need to get the vaccine? And so let me go back to the beginning, where if Dr. Cabrera, if you can put up your COVID-19 image, if you can pull that up, okay. So, the way to get immunity, there's 2 ways. There's natural immunity, meaning you get that from being infected with COVID, and when that happens, your body develops antibodies to these spike proteins that are pictured here in red. So the antibodies, which are sort of Y-shaped, that attach to these spike proteins and covers it, right? So I'll get back to that later. And then there's the second type of, yes, thank you. And then there's second type of immunity, which is vaccine-induced immunity. So with getting a COVID infection, you run the risk of getting severe illness, and then also you run the risk of getting hospitalized and even possibly death. So if you want to weigh which immunity, I would highly recommend the vaccine immunity, vaccine-induced immunity. And so if you did have COVID, you are, it depends, right? There's a range of symptoms, and that's why COVID-19 is dangerous, is because you could be asymptomatic, which means no symptoms, or you could be on a ventilator. And so if you did have COVID-19, what studies are showing is that people with with no symptoms or very mild symptoms did not develop these protective antibodies. And so you can get the vaccine to help increase you can help get the vaccine to allow your body to produce the vaccine-induced antibodies, which will prevent any further infection with COVID-19. And you can get reinfected with COVID-19. My friend, His first infection, he did not have any symptoms at all. He got reinfected and he was hospitalized for 4 days. Unfortunately, he has fully recovered. And so if you had COVID-19, do you need to get the vaccine? Yes, you do. All right. So does it protect against the new strains? If you can pull up the picture of the coronavirus again, Dr. Cabrera. Okay, so here we see the spike protein, right, in red. And imagine you have, all these antibodies, which are Y, they're Y-shaped, and there are millions of them that are floating around in your body after you get the vaccine. And so what these spike proteins do is the virus uses them to attach to the cell. So it's like hands or grabbing on to your cell, and then it uses that to insert the machinery of making more COVID-19 virus. So the antibodies cover these spike proteins and prevent the virus from attaching to any cell. So that's how it protects you if you are exposed to COVID. That's how the vaccine-induced immunity helps protect you. With the new strains, there's little tweaks, there's little changes to the spike protein in red. So sometimes antibodies, sort of natural antibodies, correct? Thank you for that picture, Dr. Rivera. Sometimes the antibodies from natural infection are not able to fully attach or fully cover these spike proteins. With the vaccine-induced immunity, vaccine-induced antibodies, the companies Pfizer and Moderna have tested their vaccine-induced antibodies on these new strains in preliminary studies, and they have shown to prevent infection with these new strains. So the antibodies work and attach quickly to these new strains that are produced, the antibodies that are produced by the vaccines. So does the vaccine protect against new strains? Yes, they do. All right, I'll stop here and then I'll answer any more questions at the end. Thank you.
Thank you very much, Dr. Cruz. We'll go ahead and move along here. So just circling back to myself, and how are we going to get the vaccine? Go to Dr. Luis Cruz right now. I'm just kidding. If you're actually part of the eligible criteria, then I'm not kidding. And so, but basically, I just wanted to review where we're at in terms of the CDC's phase allocation overview. Now, this was their initial recommendation, yet local jurisdictions have and in fact, we're encouraged to look at their needs and their situation locally, and then tease out in terms of how to actually phase in certain people, even within certain groups. But as you can see here on the left and the right, that there's basically two main principles here that we're trying to achieve when the vaccine's still being limited. And one is prevention of morbidity and mortality, and then number two is preservation of societal function. And so basically, number one, it's the long-term care facility residents. And so especially stateside, for example, these are some of the most vulnerable. And so that's why they're considered category 1A. Here on Guam, there's not many long-term care facility residents, but one good example is St. Dominic's as the residents there. So they were one of the main priorities of getting vaccinated. Then of course, healthcare personnel. And then 1B is persons 75 years and older, and those are definitely being vaccinated here in Guam right now. And then frontline essential workers, and I'll just move to this slide because it actually shows where we kind of are at. There's a reason why I put some check marks here, but I'll get to that a little bit later. Frontline essential workers is more like a yellow light. Some have green lights and some are still waiting. But in 1C, we have persons 65 to 74, but here on Guam, we actually brought that age down to 60, and I'll show you why in a minute. And then persons 16 to 64 with high-risk medical conditions, there are some scenarios where we are allowing that right now. And when I say we, I actually mean the vaccine and antiviral prioritization policy committee, which the 4 of us are on. And so so help us make these recommendations. And then here, other essential workers as part of 1C. But what is that? Who does that actually mean? So we already talked about 1A, and so that's clearly the long-term care facility residents and the healthcare workers. But in 1B, first responders like firefighters and police officers, correction officers, and then public transit workers, especially school bus drivers and those that are GRTA that are transporting, in particular, persons with disabilities. And then the education sector has been given the green light, and this is teachers and support staff, as well as childcare workers. We will be circling back to these other persons in 1B as we move forward. And as you can see here, when it comes to age, we actually dropped it to 60 to 74. And then the part about 16 to 64 with a comorbidity, it was more specifically of them being discharged from the hospital and having a high-risk comorbidity. And that's, of course, to be ordered by their attending physician. So why the 60 to 74-year-old? In fact, there was a good argument for it to be even 55 and older right off the top. This here is basically the COVID related deaths that we've had here on Guam. And so this is the first 100. And we have 129 deaths, but this is the first 100 and the breakdown by age. And so as you can see, there is a big jump from the 50 to 54-year-old group to the 55 and 59. And then you can see that that jump and as it goes up in terms of percent of deaths. But really, when you look at it, deaths per 100,000 population of people in that age group, you can see as it goes up much higher. Basically, when you see that there's only about 469 estimated people over 90 years old, and 5 of them have died already. That's pretty high percentage-wise. But also look at the number of the population itself, and just the 55 to 59, there's almost 10,000 of them. And so in trying to balance that, we wanted to go down as much as we could, and at this point, especially with the vaccine supply, we felt that this was an appropriate place to start. Instead of 65, was to drop it down to 60, and it's very likely that we'll drop it down to 55 or lower, in the next few weeks, depending on how our vaccine supply is. And speaking of which, so this here is a little bit more about the breakdown in age, and I want to show you something that's extremely impressive here. So this is the age group 75 and above here in Guam, estimated population size. The number that have gotten their first dose already, that's 84% of our ultra manamku who have already gone out and got their first dose. They know the major benefit over the risk when it comes to this vaccine. They have demonstrated by going out in the toughest conditions for them and gotten the vaccine. And already 28% of them have already gotten their second dose. And so they, the rest of them, their time will come when they get it, because you get it two doses, and anywhere from 3 to 6 weeks apart, you can actually get it. And so not as much penetration into the 60 to 74-year-olds. 19% have gotten their first vaccine. And so you can see how it goes from there, but they'll get their more opportunities, especially when the greatest generation was definitely given first dibs, and I think that most of the 60 to 74s may have been deferring to them, but then now they're coming out. And so how are we doing overall in terms of our trajectory with vaccines? So here you can see it's the bars is the cumulative number of people we've vaccinated, and then this is the trend here. But if you were to extend that out further, and as we keep building up and being able to vaccinate more at a faster rate, this is basically the trend that we're on. And let me just say this, that there are 125,000 or so persons that are 16 years and older on Guam, because the vaccines are not yet, none of them have been approved yet or authorized yet for persons below 16 years old. And eventually they will be. but if you take 80% of the 125%, that's 100,000. So basically, to vaccinate 80% of 16 and older, we need to give out 200,000 shots. Where's 200,000? It's over here. And when is that? That's like end of April, early May. So at the rate we're going, we could theoretically vaccinate 80% of mostly of our adults plus the 16 and 17-year-olds, by then. But the biggest rate limiting steps are the supply in terms of when the federal government gives it to us, and what's really going to be the challenge later here. And this is why we really hope that everyone in the chamber can really help us with this in this messaging by learning what you're learning today, and then keeping up to date, and then in ensuring that you help us with the conversations about the importance of getting the vaccine, especially as we get down into the lower age groups, because the demand is likely going to wane, and so that's what's going to make this this trajectory actually come down from there. And that's it for slides. I'm going to stop sharing my screen, and then we'll go to and try and answer any other questions that come up. Thank you.
We do have a few questions from our viewers. The first question is it safe for me to take the vaccine if I have other diseases such as diabetes and hypertension?
I'll defer to one of my colleagues here if they want to go ahead and take that question.
Sure.
Okay.
I'll jump in. Yeah, so it is safe. In fact, these vaccines have been given to many people with diabetes and hypertension. And in fact, the only contraindication for not getting the vaccine is if you are one of those, 10 people that got Moderna and had an anaphylactic reaction, or if you, for some reason, had anaphylaxis to one of the components of the vaccine. But otherwise, there are no other contraindications for having the vaccine. That being said, people who have had allergic reactions, they ask them to, they monitor them a bit longer after they have the vaccine for 30 minutes just to make sure they're safe. And then also for pregnant women and women who are breastfeeding, they allow women to, of course, make that decision. It's a decision that they would sit down with their provider and talk about the benefit of getting immunized against COVID-19 and that risk of having severe COVID-19 that we know pregnant women can have versus the unknown risk of what these vaccines, how they may play out for pregnant women. But as far as for diabetics and hypertension, that is not a contraindication. And in fact, those are the individuals that we really want to protect from severe COVID-19 because we know that those individuals are at highest risk of having severe COVID-19 and death. Thank you.
Thanks, Dr. Hancock. I just wanted to add real quick also, say, well, the question is, how do you know that, right? How do you know it's okay? Well, as Dr. Hancock mentioned earlier about these randomized controlled placebo trial, that when you have this whole big group, over 20,000 of placebo group that actually didn't get the vaccine, so they're not biased, and their people giving it to them are not biased. And then you have the group that actually did get the vaccine, and what they do is they look at them and they compare them up, and they match them up and see how well they compare. And if one group had like too many people with hypertension and the other didn't, then that's not balanced, and that's not true randomization. So what you see in these studies, they show it to you right there. What percentage hypertension, and you see that it matches up for both groups. And so that's the way that you can see that there isn't more side effects for one versus the other. Same thing, and you do that across the board in a lot of different aspects, including ethnicities. And so that's an important part. Now, for example, the Pfizer trial, that was include the United States, South Africa, Brazil, I think even part of Argentina, and it was pretty well balanced. And actually, even native Pacific Islanders were balanced in the placebo and the actual vaccine groups, and that you saw a decent percentage of them, and them compare up. So I just wanted to point that out, at how intricate this is and what the power of the data that's there that can actually help us be very comfortable with an answer like that. Thanks.
Thank you, Dr. Cabrera and Dr. Thane. The next question is, how long does the vaccination protect us? There is information going around that it is only good for 1 year.
I'll take a shot at this one. So Moderna actually came out with a study reporting that the vaccine-induced immunity may last a couple years. And of course, that's been continuing to be studied continuously as far as if the vaccine's being effective. And so, they're showing that natural immunity is likely to be, 6 to 7 months if you develop natural immunity after being infected. But the vaccine-induced immunity, they're reporting, Moderna specifically, Pfizer hasn't reported. I haven't heard any studies from Pfizer yet, but it likely will be similar that the vaccine-induced immunity will last at least a year, a couple of years. Thank you.
Thank you, Dr. Cruz. The next question is, what is the maximum wait to receive the second dose after receiving the first?
I'll go ahead and take that one, just because it's one thing that's gonna come up a lot, and I want to be sure that everybody's very clear about this. So right now, so they're still studying this, right, about the maximum weight. So what, in other words, as I understand the question is, if I take the vaccine on this day and I'm supposed to be due on, let's say, 21 days later for the Pfizer or 28 days later for Moderna, how much longer can you push that out and it still be effective and not have to restart the series again? So the honest answer is that we don't know exactly how far out, but what we are comfortable with, and even what the CDC is comfortable with, is saying that if there are vaccine supply issues, that it should be no problem of waiting up to 6 weeks. Like, you really want to get it within 6 weeks, and that's for both vaccines. So the Moderna, I'm sorry, for the Pfizer, that basically doubles the time to 42 days, and then with the Moderna gives you that additional 2 weeks there. And so, but then they even say if there's a special reason why you get it even beyond that 2 weeks after you're due, then that's okay. Still get it. You don't have to restart the series. And in fact, I'll go even further, that the WHO, the World Health Organization, is actually saying that if the circumstances are pretty extreme, that 4 weeks after is totally fine and should be okay. So so I don't want people to worry too much about that. What public health and all the other vaccine sites are doing and are trying to do is really give the reminder calls. Right now, there's about a 93% compliance rate of people coming in and getting their vaccine, exactly within that 21 or 28 day or 21 day, because actually it's only Pfizer's right now that are being due. And so they're being very good about it. But we are running very low on Pfizer, and we've been trying to give out as many first shots as possible. And so there's some people that are going to just have to wait. They're going to get it 1 week later. And I'm saying this because I did it myself. I purposely waited one additional week. It was because I just didn't want a chance. I was on a pretty busy and stressful inpatient rotation as a hospitalist, and I didn't want to jeopardize that time. And so I just waited a week until I rotated off service, and it was fine. And actually, it did get. I was one of the 4% that got a headache after my second dose, and it wasn't too bad. But I'm pretty glad I didn't have to work so hard with that headache. That went away just the day after. So I just wanted to make sure that we're very clear and we set those expectations that it's okay to wait a little bit.
Thank you so much, Dr. Cabrera. The next question is, vaccines protect the individual and population, but how do we remain reassured we are getting close to herd immunity?
I guess I'll try and answer that. That's a very good question. But what I think is important, and what we saw that was important with this surge that we had in the fall, is that if we are not overwhelming our hospital system, our fragile hospital system, then that's a very good indication that we are very, we have obtained herd immunity. If we open up our economy, we vaccinated 80+% of our population, and we are not overwhelming our hospital system, and we have reduced number of infections, then that's a very good indication that we have reached herd immunity, and we can continue to go about as lives as we know it, as far as returning to some type of normalcy. Thank you.
I just wanted to add to that because I think that's a great answer. Is that I went into a little bit of history about smallpox, and if you guys never known anybody with smallpox, that's probably because you're like me and you're born in 1980 or later. And because smallpox was eradicated from the world, essentially was declared eradicated in 1980. So what happened in 1957 or so, there was a campaign to get down. Many countries, many better off countries, already had herd immunity to smallpox, but there were a lot of other countries where it was still very much endemic. And so there was a push to eradicate. And then by like 1967, a lot of money got pushed into it, about hundreds of millions of dollars in that time. And in 13 years, they managed to go get enough vaccinations around the world to eradicate it. And they didn't vaccinate 100% of people. They vaccinated enough to reach the herd immunity that smallpox just had nowhere else to go but die and go away, and then only be made up in some lab for that biotourism, as a potential for that. So and so that's why we still keep the vaccines on hand. The stockpile, is there for FEMA or somebody, I'm sure, has it. So I just wanted to share how that history and how we can learn from that history. Now we're doing this at a much more accelerated rate than with smallpox, with so much more resources. And so it's not going to take us 13 years to get that herd immunity, but it will take a long time for us to eradicate coronavirus from the world, if we can ever do that.
Thank you, Dr. Cabrera. The next question is, even with vaccines in the community rollout, how important is it that we continue to do serial antigen testing for teachers, healthcare workers, and other frontline and essential workers?
I've been trying to give Dr. Lee a chance to jump in here, but
Sorry about that. Sorry, actually, so in terms of like serial antigen testing, so this is my thought. A lot of these screening tests are actually, so number one, in terms of like the accuracy of the screening tests are really dependent on how symptomatic the patients are. And in regards to like what we have available, really we should be reserving our tests for patients who are symptomatic. And so, in terms of like, do we need to be serial testing people who are exposed, on a regular basis? My answer would be no. And I would build that from my own experience, in the sense that, I work in a clinic, I take care of COVID positive patients on an outpatient level. These are patients that don't have to be hospitalized, or I take care of them right after they're discharged from hospitalization, not necessarily cleared from public health yet. And my staff helps me and assists me in taking care of these patients. And no, we don't serial test at the clinic. The time that we do test is if, number one, we've been identified as a positive contact for someone who has tested positive, or number two, if we are symptomatic and we are concerned that we're possibly positive for COVID. So I don't, and again, the other panelists are welcome to correct me on this, but I don't believe that it is necessary to serial test population simply because of the possibility of exposure. So I would say that that's not necessary. I think that we need to continue to follow the guidelines that are in place for us. Again, if you're identified by contact tracing as someone who has come into significant contact with someone who is identified and has tested positive, then okay, you should be tested. And the other situation would be if you are symptomatic, and that's when you should be tested. So I hope that answers that question. Thank you.
I would like to add to that from a sports side. So that serial antigen testing may be important when we start trying to go back to more of the high-risk sports such as football, rugby, basketball. And that's where serial testing can come in handy, just to make sure that no one playing or no one in a game is symptomatic or infectious at that time. So that's where I think moving forward, if we can get the younger people vaccinated, then we may need to do serial testing.
Thank you, Dr. Lee, and thank you, Dr. Cruz. The next question is, what are your recommendations with testing at the airport instead of quarantine?
I think Dr. Hancock's going to want to take this one. I keep putting them on the spot.
All right, yeah, I think our tests don't catch 100% of individuals infected with the virus. You can be infected, but your test can still be negative. So you can, test negative, go through the airport, and then infect others in Guam. Now, we know that unfortunately there's these new variants circulating in the world. We're testing to see if we have it on Guam, but just by looking at our numbers, we're fairly confident that we probably don't have one of the really infectious variants here, but we could potentially get it. So while our community is not fully immunized, while our numbers are much lower and we're starting to open up our community, and while the cases in the US are still quite high, fortunately they've been coming down a little bit, but there's also that the increased threat of the new variant. I personally feel that keeping that tight travel quarantine and really reducing the opportunity of these new variants to get introduced into Guam, especially while we're opening up because our numbers are so great, I think is really important. And unfortunately, just one test at the airport is not enough to really identify all those cases. Now, I bring that up. I know that travel quarantines are not convenient. They are expensive, and we're having the cost of it is quite a bit for that benefit. And perhaps as Dr. Cabrera showed that slide and the work that Major Cruz is doing, and helping immunize our community, what will happen is we'll get to a point where we'll feel is better protected, and that risk of allowing the new variant in is going to be reduced, because we feel like, all right, well, even if it gets here, it's not going to cause an explosive outbreak and overwhelm our hospital and that sort of thing. So they'll probably get to a point where we do just rely on a test and not the travel quarantine. But at this point, and this is my personal opinion, at this point, when we're finally getting to open up, schools are back in session, we've got low numbers, I think it's really important to try to maximize that disconnection of Guam from the rest of the US cases and prevent the introduction of that new variant. And because we don't have a test that's 100% sensitive, we need that quarantine, those few days, for people to hang out and not infect others and get tested again to see if there are any cases hidden there. And we've been seeing in the numbers that the percentage of positive cases in Guam that are identified in the travel quarantine are just going up and up. I think last week is 40% of our cases were actually identified in travel quarantine. And so I think it's doing important work, even though it is extremely inconvenient and burdensome.
can I just make a quick plug and just to note that since we are speaking to the Guam Chamber of Commerce and the Women's Chamber of Commerce, that when we want to be similar to the CNMI or Taiwan, we just have to do what they're doing, basically, where they understand the focus of quarantine being the key to having a more normal society and being able to reopen businesses. And so, when you think about that and what Dr. Hancock just said, that where community cases are going down, and a lot of our positives are really just coming from because we're catching them. And imagine each one of those persons could be a big flare-up, could be a big cluster on their own, and we're catching them. So the importance of good quality quarantine and not and really patching up any of these porous parts where people are making every excuse to say that they're essential and that they can be on a restriction of movement. And so those are the kind of things that we're focusing on, because we're knock on wood, doing a much better job of our cases now, but it does make it more focused on quarantine and doing it in the least restrictive way, but still in the most effective way. Thank you.
The next question is, I am a polio person having that virus in my body. Do you recommend inoculation with either of the two vaccine types?
Sorry, Crystal, could you repeat that first part?
I am a polio person having that virus in my body. Do you recommend inoculation with either of the two vaccine types?
I just want to clarify. So the first part of the question is, you're someone who has a history of polio, is that correct?
That's what it appears like. I am
Okay.
a polio.
So someone who has a history of polio infection, and so their question is, would it be okay for them to be vaccinated with either of the current vaccines that we have available? Is that right? I just want to make sure I'm answering the question.
That is the question. Yes, that is the
Okay,
question.
all right, okay. So, again, as we've stated before, I think it was Dr. McCullough who stated before that the only contraindication that we have, and when we say contraindication, it means that this is it means that the patient or the person is not eligible to be inoculated or vaccinated. The only contraindication that we have at this point is if you've had a very severe reaction that possibly almost killed you to a previous vaccine. And we describe that as anaphylaxis, in the sense that anaphylaxis is when you swell up and you stop breathing. And so right now, that is like the only clear contraindication we have to receiving this vaccine. The other possible contraindications or relative contraindications that we have would be if you've had an immediate allergic response to, like the first COVID vaccine. And so in terms of having a previous infection with a different type of, previous infection or having a different disease, infectious disease, is not a contraindication and is not a reason not to get vaccinated. So, as per the current guidelines that we have, if you've had a previous infection with a different disease, you are free to get the vaccine. And then also to just reinforce the question that Dr. Cruz answered, that if you have been infected with COVID-19, because of this question as to how long natural immunity lasts, we do recommend that you do get the vaccine. Now, if you did receive treatment with monoclonal antibodies, right, which is one of the treatments that we do have for patients who are infected with COVID-19, we ask that you wait 90 days after that treatment to receive the vaccines. So I hope that answers this person's question. Thank you.
Thank you, Dr. Lee. Next question is, with the new strains of COVID arising, is it more imperative that people get the current vaccine now to protect from illness and potential transmission to avoid further spread and mutation?
I know I just answered, but is it okay if I answer this one as well? Okay. So, as Dr. Cruz stated, the current studies that we have so far have proven effective against, the emerging variants that we're seeing in the UK, South Africa, as well as Brazil. But, so yes, it's important to go ahead and get vaccinated, not only because the current vaccines that we have are protective against these variants, but I think it's also very important that we move very quickly to get as much of the population vaccinated as possible. And the reason for this is the reason why variants emerge is because the coronavirus that is causing the COVID-19 infection is an RNA virus. And what does that mean? It means that as it replicates, as it, makes more copies of itself, when it infects someone, it doesn't have the machinery or doesn't have the corrective mechanism to be able to ensure that that replication of the RNA is accurate. And as a result of that, this is how we get these variants. So if you think about it, the more infections that we have, the more possibility for variants. And so this is another reason why we can look at vaccines as a way of protecting us against the variants, not only because they're currently effective against the variants that are currently in play in the world, but also too by reducing infection and reducing the possibility of continued replication within the human host, will also possibly prevent the possibility of replicating so that it produces new variants. So this would be a reason to say, yes, it's good to go ahead and get the vaccines that are currently available to us and to get them as soon as possible. Thank you.
Thank you, Dr. Lee. Next question. When do you think the healthier population of 64 and younger without medical conditions can get the vaccine?
I'll go ahead and take that, just because it has to do a lot with our rollout. Well, I'll tell you this, as in the slide that I show where we're on our trajectory right now, it really depends on what is going to be allocated to us from the federal government and how quickly it'll be allocated. I'll just say this, that we are making, we're trying to work every angle to make the argument that saying, hey, US, you want an easy win, get all of the vaccines that's necessary to all the main Pacific Island territories, so that we can achieve herd immunity very quickly because of how vulnerable we are in this vulnerable place, and get some wins with us. And because we are actually leading the country. And in fact, I just want to pop this up here. And so this is from Bloomberg. And what this shows here is all the states and territories, and it's a range right now by a percent. The population given at least first dose: American Samoa 16.5%, Northern Marianas 11.6%, Alaska 11.6%, and then we're right now at number 4 at 10.3%. And so, of course, once they see our updated numbers, we're gonna do better. But we've been sitting. I think we've been mostly trading places with Alaska every other day or so. But this is great when you look at it. West Virginia's been getting a lot of credit throughout the country, and they're doing good, but we're still doing better than them. And when you look at all these other places, Texas, they're way down here, and then Missouri way down there, Puerto Rico, unfortunately. And so because of the speed that we're going through, so in all likely we already are very much ahead of a lot of the country, because we're already allowing 60-year-olds to get the vaccine, which is below that 65 part, which is the next step. A lot of places are still just trying to get their 75 and older vaccinated. So at the rate we're going, it will probably be just a couple more months until even a healthy person between 16 and 18 can be able to get the vaccine, and we hope to do that very quickly. So again, it's still hurry up and wait, but we're still way ahead of the curve, and we're going to probably be doing that much sooner, much faster than the rest of the country. Thanks.
Thank you, Dr. Cabrera. I wanted to add that we're also one of the few places also vaccinating our school-based staff. So that's another milestone for Guam. The next question is, some businesses were asked to participate in a vaccination prioritization. What are the plans to work with businesses to conduct vaccination clinics in the future?
think short answer to that is that we are already working with the private industry. In fact, we wouldn't be able to do what we're doing without the help with the private industry, and that specifically being GRMC, AMC, FHP, SDA, IHP, Tumon Medical Clinic. So you have all these private partners that are helping with the vaccine rollout, and basically more are even coming on online, and also Rexall Drugs, for example, is the first pharmacy and they have to meet the CDC requirements in order for storage and being able to be an administrator of the vaccine, and it takes some time, and but remember, safety is number one, and also the last thing we want to do is to inject spoiled vaccine, and so that's why it's very important about having these quality control measures in place for a clinic or a private entity can be one of the vaccine providers, and so that's really where we're at. But I'll be honest, if there's any of the other if there's any other people on the island, any groups, any specific businesses that want to help out, like for example at UOG, and they're sometimes they just need people who can just do some simple screening and help process the people. And if people want to volunteer and have a commitment, so not just like I'll come for a couple hours, but commit like a good half day or better yet a full day, like those are really tangible ways that can be that can work. And so if that's something that's for offer, then I suggest that you speak to one of two incident commanders. And so one is Public Health's incident commander, and that's Tom Nadeau, and then Guam National Guard's incident commander, which is Dr. Luis Cruz. And so, and if there's a strong commitment, I think that can go a long way. Thanks.
Thank you, Dr. Cabrera. And the next question is, in an earlier report from Department of Public Health and Social Services for vaccines given on Guam, we had 3 people with negative reactions. What were the side effects of these 3 persons? Did any of these 3 persons still have any health issues now? If so, what are the health issues, if any?
So real quick answer to that is that all 3 of them were not serious. None of them were anaphylactic. We thought one might be, but it was not, and they're all doing fine.
Thank you, Dr. Cabrera. Next question. Can a person receive different vaccines? For example, first shot is Moderna, the second shot be Pfizer, or first shot Moderna or Pfizer, and the second shot, or be the new Johnson & Johnson single shot vaccine? It's about mixing brands.
I say get all of them. No, I'm kidding. No. So yeah, they don't recommend mixing brands at all. And it's not the end of the world if you do, but they'll pretty much consider you as getting a second shot if that accidentally were to happen. But that's why it's very important to have your vaccine card. I know it's a good time. I want to be sure I show this off for those who haven't seen this yet. This is a hot commodity. It's our vaccination card. And so basically it shows you the brand of what you got, and then making sure that you also get the same brand at for your second dose. And so so that's one sure way that you yourself can ensure that you get the right vaccine. But of course there's a number of checks and balances, but like anything else, Swiss cheese whole, there'll be a very rare, but okay, this person that's going to fall through the cracks and actually get the wrong vaccine. But hopefully that doesn't happen here in Guam, and that's I'm speaking about somewhere else. Thanks.
The next question is, when can DPHSS be able to set up a testing site at RGIAA to accommodate visitors arriving as needed and visitors returning to their home country?
Dr. Cruz, you want to try and answer that?
I'm sorry, could you repeat the question?
Of course, Doc. When can public health set up a testing site at our airport to accommodate visitors arriving and visitors returning to their home country?
Okay. Well, I think the challenge is that we don't have enough of those quick tests because the surge was still going on in the mainland US. So those really rapid tests, which are sort of made for mass testing or useful for mass testing, those aren't available at this time, and we don't have a very steady supply coming in. So that is the limiting factor right now. If we had 100,000 test kits coming in, I think we could have opened that up sooner. But as you know, with the PCR testing, it's very expensive and it does take a lot of time, and so that would not be conducive to an airport type of mass testing. So it's right now it's on hold. That's something that was being planned, but because of the limited supply of these tests now, that we are unable to sustain that type of operation at the airport at this time. Thank you.
Thank you, Dr. Cruz. Is there a certain percentage of immunity that we can achieve before reaching a full 80% that will allow us to comfortably open our internal businesses?
I'm going to say this pretty clearly. We don't have to rely on the vaccines to do that. And what we do have to rely on is the proper mitigation efforts that's necessary, and for us to ensure that we have really good quarantine and we're able to do more of this. But so I want to be clear about that. But overall, vaccination is a long-term prevention strategy. You know, the 4 W's, again, as Dr. Lee had mentioned earlier: wearing your mask, watching your distance, washing your hands, and having the willpower to do it 100% of the time, especially when you're with somebody that you don't live with, is extremely important. And that's how we continue to open up our island. And there will be a new executive order where the governor will have some more relaxations, because we've earned it and because we've proven that we can do it. And so that's an important part. But basically, just knowing that if that we're because there's one thought about the herd immunity, in that we say 80% or so need to be vaccinated. Well, that 80% had only gotten the first vaccine, the theory is that right now it's actually believed that even just the first shot gives you that 50% effectiveness. And so the WHO was just hoping for 50%. And so even with that, we might actually be much more ahead of schedule than if we were going to fully rely on the 2 doses, even though we want that maximal effectiveness that we can get out of it. So it's hard to say how long, but we might be in for a pleasant surprise. But again, I just trying to set the right expectations. Thanks.
Thank you, Dr. Cabrera. How will the vaccinations be administered to the various essential worker categories, e.g. grocery stores, gas stations? Would you get a name list from each of these companies?
Sorry, just I guess because as the Chief Medical Officer for Public Health, and a lot of these questions do fall on under my umbrella as well. But what's important to understand is that we don't want to create more barriers that make it even harder to get the vaccine once you become eligible. And so there's a very important part of where there is a community trust in this process as well. And that, once you get to a point, but what we hope is that there's going to be just so much vaccine that we don't even, that verification even becomes less of an issue. And that there's going to be a certain amount of trust. But the reality is that we don't want to, and if you're competing with a 62-year-old that's still trying to get their vaccine, then obviously we don't want that situation. And we may throttle that and start having to do the verification. But just like the GovGuam agencies, that they have been actually creating tier groups within their own agency, in terms of tier 1 being like, these are the ones that we really want to make sure they get vaccinated first, because they have reported to us that they have comorbidities, or for example. And then so we may ask that of certain businesses that start falling into that, and they're going to come up earlier than a lot of other ones. And in particular examples, like grocery stores, for example. So there'll probably be a cross-reference with everyone who has a business license, business store license for groceries, mom and pop stores and things like that. But so it's going to be difficult, and we may, we'll welcome ideas as well from the community in terms of how best to do that, because what we don't want to do is have a massive list and try and check people off, because there's going to be people that are going to be on and off, and that's just going to be a logistic issue, and that's just going to slow down our efforts to give vaccines. And we just want to get as many shots in arms as possible. And so you're going to hear some reports about, there's some people that are getting it that aren't in the eligibility criteria. So yeah, that's right. We are giving it to some people, and that's because we don't want to waste any vaccines. And so when you have a Pfizer vaccine, when you draw up, once you access and you start drawing up, and you only had 2 more, but you have to open up 1 vial, you're gonna have 3 more shots. But guess what? We've been drawing out an additional 6 shots out of the 5, and some of the vials we're able to do that, and we don't want that to go to waste. So we look at if there's anybody else around, depending on the situation. Like for example, at GRMC, there was a visitor that happened to be coming by, or then they asked, hey, do you want to get the vaccine? There's 3 extra. There's also been scenarios where some of these other agencies that have a list where they'll call them and say, hey, come and send your tier 1 persons, because we have we have this many vaccines available for today. So yeah, so that's gonna, those scenarios are happening, and they're, it's not going to be 100% fair, but in the end, it's going to still be another person that's going to not give us COVID in all likelihood.
Thanks, Doc. We're almost done. When and where will I obtain the second shot? The COVID-19 record card does not give this information. Will DPHSS contact me? Can I go to my clinic for the second shot?
I'll just say the short answer is that you are given a reminder call, and given a instruction for the best, because what we're trying to do is create these particular clinics that are dedicated to the second dose persons. But the reality is that you can get, as long as it's the same brand, you can get it anywhere that is that's offering it, that you get access to it. So let's say you got a Pfizer first dose at GRMC for whatever reason, or at GMH, but it's more convenient for you to go to UOG. Then by all means go to UOG and go to that system. In the end, you're going to get it. They're going to verify that you're due, and then they're going to give it to you. They're not going to turn you away, especially if you're due. Thanks.
Will you only have to get vaccinated once, or would we be vaccinated yearly like the flu vaccine?
So that's still unknown, and I think as the studies are being conducted, because the vaccine is still being studied and the antibodies, the level of antibody response or level of immunity is still being studied ongoing. So, these vaccines have been approved for 2 months now, and we're gonna, but the participants that did start the study have been in for 3 to 4 months. So right now they continue to test the people that started in the trials, and it's very favorable at this time that these vaccines are maintaining a high level of immunity, but only time will tell. So that's continues to be an unknown at this time.
Thank you, Dr. Cruz. We're down to our last 2 questions. Will DPHSS allow GVB to promote Guam in Japan and South Korea to allow tourists with negative tests 72 hours before they arrive? Can they be allowed to visit Guam for a maximum of 5 days without mandatory quarantine? This was established earlier before our CAR score was lower like today. Will this be allowed to restart our tourists to return?
Short answer is that we don't have an answer for that. We learned a lot from what happened, toward the end of summer, when we started to have these allowances, and how you do that in the most balanced and fair way, especially when the threat was more from stateside. Those are constantly going to be reviewed, and I think that's something that we need to really seriously consider, especially areas that have really good control. and again, having that minimum, the 72-hour negative test prior to arrival, and if we're able to properly do a arrival test as well, then that's going to be something that would be pretty powerful. But again, until we get a better comfort level overall, I don't think that that's something that we're gonna I say we, but something that the governor necessarily would endorse in the very near future. What I mean by that is in the next few weeks or months. Thanks.
We are down to our final question, and thank you in advance to our panelists for staying this long. Our last question is, are there vaccines developed or being developed for people or kids below 16 years old?
The Moderna trial, I forget which one, Pfizer or Moderna, one of them already has this trial that's looking at 12 to 15-year-old right now. And so actually, it's the Pfizer one, the 12 to 16-year-old. And so they're ongoing trials, and it's the first parts of the safety. Once they feel more comfortable and as they move forward, then they'll go down to another age group. Probably it's going to be 9 to 12 or something like that. So they'll keep working their way through. And what's the greatest thing about this is that the people who are not yet the age groups are not yet eligible for the vaccine are the ones that spread it the least. In all fairness, right? And so we know that studies bear that out, that kids are actually not the biggest spreaders, and we think of them as petri dishes sometimes, but the reality is that they have smaller lungs than the rest of us. When they cough or sneeze or speak, it's not as we can definitely spit farther than them and definitely sneeze farther than them. And so in understanding that, but that is definitely being worked. And that's why when we started to think about full herd immunity, we have to really think about the adult part more so, because we don't know when the children are going to be able to be vaccinated, and that may not be even to the second half of the year. And so we're focusing on the adults for sure for now.
Thank you very much. We're so pleased that you could stay this long and make your presentation today. We would like to really, truly thank you, Dr. Cabrera, Dr. Cruz, Dr. Lee, Dr. Hancock, and Crystal, the governor's office. And on behalf of the Guam Chamber of Commerce, the Guam Women's Chamber, and the Guam Hotel and Restaurant Association, we bid you farewell and good evening. And until we see you again, have a good one.
Good night. Thank you so much.
Good night.
Thank you. Get vaccinated.